Hey everybody, today we're going to talk about how physicians generate revenue. Physicians have many potential sources of revenue, including things like ancillary services, external support, patient billing, revenue sharing within the practice, and various incentives and bonuses. For most physicians, the primary source of their revenue is through patient billing, which is primarily related to the quantity of healthcare they provide. However, with the triple challenge of healthcare at this time of cost, quality, and value, this is changing. Now, the primary source of revenue for physicians is expected to be not only quantity, but quality, through two programs called MIPS and APM. The Medicare Access and Chip Reauthorization Act of 2015, also known as MACRA, requires providers to choose between two payment pathways, a merit-based incentive payment system or an alternative payment model. Both of these payment models combine volume and quality factors to determine payment, and this is beginning very soon. Data collection for these models begins in 2017, and bonuses and penalties under these programs start in 2019. The merit-based incentive payment system is a bonus and penalty system with a bonus up to 4 to 9% per year or a penalty of the same magnitude. Primarily focuses on quality, resource use, advancing care, and clinical practice improvement. The alternative payment model is a bonus system only. It can pay a bonus of up to 5% per year. It relies on factors like being in a certified patient-centered medical home, chronic disease management, resource use, and access to health care. So what this does is it sets up physicians to have their revenue primarily derived not only by quantity-based services, but quality-based services. However, it is still primarily a quantity-based game. So to document the quantity of medical services that you provide, you need to submit medical bills. A bill has four primary components, things like patient information, insurance information, CPT codes, and ICD codes. We're going to talk in detail about the CPT and ICD codes. And the codes that you submit for these two categories is dependent on the adequate and appropriate medical documentation that goes into your notes. So the billing process without insurance is very simple. You have a patient encounter, you submit a bill to that patient, and then they pay you for that service. Insurance makes it slightly more complicated. You see the patient, you code the visit, you submit your billing codes to the insurance company, and then you're paid based on the services you provide. So in other words, evaluate and treat the patient, convert your documentation to CPT and ICD codes, submit those codes to the insurance company, and then get paid by the insurance company. This is also sometimes referred to as a revenue cycle, because sometimes the claims that you submit are rejected by insurance, and you have to begin the process over of coding and resubmitting the codes. It's estimated that about 10% of medical billing claims are rejected by insurers, but the exact magnitude of this problem is unclear. Top reasons for medical claim rejection are submitting a duplicated claim, submitting a claim without required information like a patient name or an insurance policy number, billing for a service that was already paid for in the context of another service, billing for a non-covered service, or filing the claim very late. Most of these reasons for claim rejection can be addressed by quality billing software, so these should not be major problems. So how long does this process take? Well, the revenue cycle is a variable length. The time from encounter to coding is physician dependent and is hopefully very short, ideally immediately or less than a day. Then you turn the billing codes into your billing department and they submit them to the insurance company. The timing from the submission of codes to payment is limited to about 21 days in many states. And the overall duration of the cycle is 60 to 90 days from the date of the patient encounter. This takes into factors such as weekends, holidays, high processing volumes, and claims being rejected by insurance. So what determines the payment amount? Well, it really is based on the medical service provided, and that's defined by current procedural terminology, or CPT codes. These are codes for services provided, such as a hospital admission, a follow-up visit, a procedure, a laboratory test, an x-ray. Some of these codes have levels of service, such as 1 to 3 or 1 to 5. This is particularly true for services such as hospital or outpatient clinic visits, and higher levels result in higher payments. Procedures like a knee replacement or a cholecystectomy do not have levels of service. So what supports billing for a CPT code? Well, it's really based on the medical documentation, which may be in the form of your H&P, a progress note, an operative note documenting a procedure you performed, or an order for a test or imaging study. And it's also supported by diagnosis or ICD codes. So in the context of a medical bill, CPT codes are service codes. ICD codes are diagnosis codes. So what are these ICD codes? Well, it's part of the International Classification of Disease system, which has been adopted by Medicare and Medicaid as the billing codes for the United States. So as an example, for a hospital admission, we'll talk about the different levels. Initial inpatient evaluation level 3, or CPT code 99223, has a Medicare allowable charge of $204. And that $204 is the same if they're admitted for pneumonia with severe sepsis or an acute myocardial infarction. Because it is independent of the diagnosis, this is service-based. A level 2 initial inpatient evaluation, or CPT code 99222, has a Medicare allowable charge of $138, and an initial inpatient evaluation level 1, or CPT code 99221, has a Medicare allowable charge of $102. Most of the leveled CPT codes show a similar pattern when going from the lowest to the highest level. The Medicare allowable charge roughly doubles. A total knee replacement is a little different. The CPT code is 27447 with a Medicare allowable charge of $1,682. Note there are no levels, and it does not take into account the indication for the knee arthroplasty. This may be due to septic arthritis, trauma, or osteoarthritis. So how much does Medicare actually pay for these services? Well, Medicare pays for 80% of the Medicare allowable charge. So Medicare pays 80% of that, which is insurance claim number 1. The patient is responsible for 20% of that unless they have a supplemental policy, which would be a second insurance claim. These total up to be the Medicare allowable fee. So we'll go back to the example of a hospital admission. For a level 3 hospital admission, the Medicare allowable charge is $204. Medicare will pay $155 for the service. The patient or a supplemental policy will pay $42 in addition to the initial $155 to total $204. The revenue cycle gets more complicated because of supplemental insurance, where you have two tracks in parallel, where you have to submit your billing codes to two different insurance agencies. And many supplemental policies will delay payment until payment is authorized by the primary insurer. So that's how physicians generate revenue for their practices, primarily focusing on the quantity aspect of physician revenue generation. And you need to think about how quantity plays into the healthcare challenges of cost, quality, and value.